Improving resident competency in ambulatory care through high-yield ambulatory noon didactics, the HAND series. My name is Dr. Jazdeep Bathla, and my co-authors include Dr. Mohiuddin, Damugatla, Paulina, Gomez Pinheiro, Surapaneni, Fatiwala, and Rahim. We are from the Department of Internal Medicine at Detroit Medical Center, Wayne State University. Ambulatory care represents a subsection of internal medicine focused on providing primary care services such as prevention, treatment, as well as follow-up for common medical conditions. Due to our training program's location in a major urban center, effective primary care is essential in serving the surrounding underserved population. Along with exposure throughout multiple outpatient centers around Detroit, including the DMC General Medicine and Pediatrics Clinic, our program also utilizes the online modules provided by the Johns Hopkins Physician Education and Assessment Center to boost resident understanding of common concerns seen in the outpatient setting. Following the COVID-19 pandemic and the reduction in outpatient and elective services, training lapses at all levels led to a decreased experience in the outpatient setting. Our program also utilizes a 4+1 schedule consisting of 4 inpatient weeks and 1 outpatient week. This contributes to limited continuity of care during our 5-week rotation blocks. These factors have resulted in poor resident performance on the American Board of Internal Medicine, specifically the ambulatory portion. The goal of our study was to improve resident core competency in managing common conditions encountered in the outpatient setting. We sought to accomplish this through a dedicated formal didactic series. The purpose was to provide a supplement to the hands-on clinical experience obtained from our outpatient offices. Also, by dedicating formal education time, we wanted to promote earlier adoption of the Johns Hopkins modules to improve board pass rates as well as overall ambulatory performance. We created an interactive, hour-long weekly lecture series focused on ambulatory curriculum that was embedded into our residency's formal education didactics program and delivered by our attending physician staff. Each lecture correlated with topics and objectives covered by the Johns Hopkins Physician Education and Assessment Center. The weekly didactic was provided to each of our 5 internal medicine residency cohorts following their Thursday morning clinic session on a 5-week cycle, consistent with our rotating schedule blocks. Following completion of each lecture, residents were then expected to complete the corresponding Johns Hopkins module for maximum knowledge retention. We used a pre-session and a post-session survey to track attendance, as well as other metrics, including knowledge and overall confidence levels. The surveys also included 4 to 5 relevant clinical questions produced by each lecturer and derived from the corresponding Johns Hopkins module. After 7 blocks, we have covered the following topics: hypertension, cancer screening, lipid management, back pain, diabetes, obesity, and osteoporosis. Our primary endpoint for the study included boosting the completion rates of Johns Hopkins modules earlier in residency to facilitate the integration of ambulatory topics into clinical skills. Secondary measures included resident comfort level in managing these topics, as well as performance on the clinical questions within each survey. Overall, our goal was to improve resident performance on national board exams, specifically in the ambulatory section. Our study implemented an RCA, or root cause analysis. The problem identified included poor performance on the ambulatory portion of examinations. Root causes included COVID-induced training gaps, poor overall ambulatory training due to limited clinic access and lack of formal education, as well as a lack of resident interest in the outpatient curriculum. The solution we developed was to create and integrate a mandatory lecture series focused on relevant clinic topics, along with the restructuring of resident schedules in ambulatory clinics to prioritize this education time. Currently, we are analyzing data and developing a response to determine the efficacy of the strategy. Another QI tool implemented in this study included the use of a PDSA cycle. Here, our plan consisted of developing a didactic series to raise performance scores on ambulatory sections of the ABIM. We will achieve this by establishing our weekly lecture in 5-week cycles and collecting data through the use of surveys. We are currently analyzing the data collected thus far and comparing it to available data from the previous years. Finally, we will reflect on what we have learned and plan future interventions. Results. Among our program of 108 residents across the 7 sessions thus far, we averaged a survey response rate of 54% on the pre-survey and 36% on the post-survey. The highest contributing group was PGY1s, with 37% of the pre-survey responses and 35% of the post-survey responses from that class. When accounting by graduating class, the PGY1 class also had the highest percent of their individual class respond to the pre-survey at about 60%, followed by PGY3s at about 52%, and the PGY1s also were the highest class to respond to the post-survey, with about 38% of their class responding. Regarding our primary outcome, we found that as of December 2023, during the midway point of the academic year, about 86% of the current PGY1 class had completed at least one Johns Hopkins module, compared to an average of 47% over the last 3 PGY1 class years. When comparing pre- and post-session survey responses, we used a two-sample, two-tail t-test, assuming unequal variances. We found a significant difference in resident-reported confidence level and knowledge level in 5 out of the 7 sessions, with a p-value of less than 0.0001, and for 2 out of the 7 sessions, diabetes and obesity, we found statistical significance at a p-value less than 0.01. We also found that for 3 out of the 6 sessions, there was a significant improvement in the number of correct responses on the clinical questions between the pre- and post-session, with a p-value of 0.001. Session 2 did not offer clinical questions. For session feedback, each hourly session was graded on a numeric scale, with 1 being the lowest and 5 being the highest. Each session had a mean grade of 4.8 or higher for both overall quality and usefulness of the didactic material. Comments included appreciation of the interactive small group discussion format, which was led by an attending physician, as well as the emphasis on high-yield teaching points. Most of our responders were noted to be PGY1 residents, which was likely due to perceived knowledge gaps during self-assessments for new interns, as well as an added motivation to follow attendance requirements for mandatory lectures. Given that the PGY1 class was our target audience for earlier use of Johns Hopkins modules, this was a positive result and likely contributed to the large jump we saw in usage and completion rates of modules within the PGY1 class this year. We are hoping that earlier adoption and integration of these modules will translate to improved performance on further assessments. Some limitations of our study included lower than expected response rates, despite mandating attendance and adjusting resident clinic schedules to prioritize educational time. Some interventions to improve these metrics include the initiation of a weekly email reminder to complete the post-survey and appropriate module, prioritizing time at the end of each session to complete the post-session survey, and an increased program-wide emphasis on mandating attendance at didactic lectures. One specific confounding factor includes the completion of 50 Johns Hopkins modules as a graduation requirement for our residency program. This may be encouraging residents to complete the required modules earlier in residency and prior to graduation. However, this effect would be less pronounced in the new PGY1 class, which is furthest from graduation, and our data shows the widespread use of these modules in the PGY1 class is more likely as a result of our lectures. We also found that the clinical questions embedded within the surveys were created by different lecturers, therefore they may differ in terms of their difficulty, consistency, and applicability. This is likely why we saw less significance and more variable p-values for each of the sessions. In the near future, we plan to develop a 3-year curriculum of ambulatory topics to cover across the duration of the internal medicine residency to ensure increased exposure to a wide range of clinical conditions encountered in the outpatient setting. Further expansion may include subspecialty topics along with a core internal medicine curriculum. We plan to continue these didactics in a small interactive group session led by attending physicians based on the positive resident feedback we've received thus far. Furthermore, we plan to complete a longitudinal analysis on resident performance on the internal medicine boards. In conclusion, our results remain significant in showing that a dedicated, attending-led, weekly didactic session provided a positive learning environment which translated to earlier adoption of Johns Hopkins modules and ambulatory topics. We found significant improvement in resident comfort levels and confidence in managing a variety of ambulatory topics, as well as performance in clinical scenarios derived from the learning modules, reflecting a deeper understanding of core topics. Thank you for your time.